Let's get started. So I'm going to be talking about shoulder dislocations in the ED. Um, we're going to be talking about pre-reduction imaging, whether or not you should do it, types of blocks, whether we could do procedural sedation, and when to consider surgery. As you can see in this picture, they're internally rotated and adducted. Often they're just squared off. You can tell when someone has a shoulder dislocation. They have a prominent acromion, and they've lost the delta pectoral groove. So whether or not to do pre-reduction imaging, some downsides, it can cause a 30-minute increase in the ED length of stay, and delays in reduction can also lead to increased risk of failure. You also want to consider whether or not someone may have a fracture. It is uncommon if a patient's under the age of 30, 35. It's also more rare in a non-traumatic mechanism. And studies have shown that about a quarter of the patients who have a shoulder dislocation will have also a fracture. There's something called the Fresno-Quebec rule. So this is a rule you could use. One thing is that it's not yet prospectively validated, but it was retrospectively validated. So again, it's a big controversy in the ED community. It's not required in all cases. In some cases, if someone has recurrent presentations or they're young and it's an atraumatic mechanism, you may not need to do it. I think for us, if we could walk them over to X-ray, it's worth it maybe, but it does increase your length of stay. So some types of imaging, one of the things you could do is a POCUS. So on the left side, we have a normal shoulder. On the right side, you have an anterior shoulder dislocation. One thing to note, though, is that you can miss a fracture on ultrasound. So for example, if you have a surgical neck fracture, that's a major contraindication to attempt to reduce in the ED. So that is something to consider because you may not see it. The next option is X-ray. We're all familiar with it. So as you can see with an anterior shoulder dislocation, the head of the humerus, it moves anteriorly, so it's not sitting nicely against the glenoid fossa. So a type of block you could do in the ED is an intra-articular shoulder block. So if some contraindications, if you're able to symptoms without having to do a block, obviously, if you have something less invasive, you want to try and do that. Also, if you're allergic to the local anesthetic, if they're altered or unconscious, if there's any sort of infection overlying the area, or if they have any neurological deficit, then you don't want to do a shoulder block for them. You want to use, obviously, gloves, gauze. You want to clean the area. And for a syringe, you can use around 10 to 30 mLs, depending on the preference. And you're going to inject around 10 to 20 mLs. And you could use 2% lidocaine or 0.5% bupivacaine. So you can do it palpation guided. You can just palpate. You want to identify the glenoid fossa. And it may be difficult in someone who's obese, so it can be hard. Obviously, you want to disinfect the skin and you want to insert the needle towards the glenoid fossa. You want to create a wheal in the area before to help with with numbing, and aspirate as you advance. If you do have blood, it suggests you've entered the capsule, but you can end up hitting the glenoid fossa without aspirating any blood. So you can use the linear or curvilinear probe. You want to enter the skin in plane, just lateral to the lateral edge of the probe. You want to follow the needle in lateral to medial into the glenoid fossa. And once you're in the joint capsule, you want to aspirate and inject. You want to obviously visualize the needle the entire time, and you should anticipate improvement of the symptoms within 15 to 20 minutes. This is another view. Basically, some complications could be that it doesn't end up, you don't end up achieving pain relief. You can end up not in the intra-articular area. You could be in the extra-articular area, and this could affect some of the arteries in the area, and you can have a nerve injury, or you can cause an infection. Another type of block we could consider is the interscalene brachial plexus nerve block. So I'm sure we're all familiar with this picture. So essentially, you could use this for a clavicle or upper extremity fracture, a dislocation, or a laceration. It numbs the C5 to C7 nerve distribution. And so you could consider it for someone who you can't use opioids, or sedation's risky, like if someone's elderly, if they're hypotensive. Contraindications to this would be infection, if they have any coagulopathy, and then if they have respiratory compromise, because one of the risks is hemiparesis of the ipsilateral hemidiaphragm due to the proximity of the phrenic nerve. So with the patient supine, you want to turn their head 30 to 45 degrees away from the side that's going to be blocked. and you can use a linear probe or curvilinear, as we mentioned, and you're going to use it in the transverse orientation. So there's two different methods you could use. You could start at the supraclavicular fossa. You want to locate what's called the bundle of grapes, which is where the brachial plexus is. And then you want to locate and you want to move caudally until you get to the stoplight. So the stoplight's between the anterior and middle scalene, and it's basically the C5, C6, C7. Another way you could do it is start at the anterolateral neck at the level of the larynx, and then you also move the probe laterally until the scalene and the stoplight come into view. You're gonna see the carotid artery and the IJ medial to the anterior scalene. You could use a Doppler to be able to distinguish between the brachial plexus and other vascular structures that are nearby. And another thing you could do is hydrodissect, so you can add some normal saline with the ultrasound initially so that you can ensure the needle tip's in the correct place. Some complications of this, including hematoma, as we talked about, the hemiparesis of the diaphragm, Horner syndrome. So what you could do is just to risk these complications, to reduce the risk of the complications, you could just use 10 to 20 cc's of lidocaine to be able to make sure you're not getting these kinds of complications. We're all familiar with procedural sedation. So this is the most common approach used in the ED. It allows for amnesia, pain control, and muscle relaxation. You could, there's different types of sedation you could do. Some of the drawbacks, there are adverse effects. So you could become oversedated, they could become agitated, they could have transient hypoxia, hypotension, they could vomit, and you need to use a lot of resources for this. So as we know, it's hard in CCT, you need to have nurses there monitoring them, and there is an increased length of stay with patients who end up getting procedural sedation because you need to monitor them after. So contraindications, like we talked about, if you don't have the nursing, if you don't have the staff to be able to monitor them during the procedure and after, then you can't do it if they have any sort of allergy. You also want to consider the fact that they could have an airway abnormality. You wouldn't be able to intubate them. If they're high risk of vomiting or aspirating, you don't want to do it on them. And then if someone's hemodynamically unstable, you don't want to do a procedural sedation on them. So setup, one of the mnemonics you could use is soap me. So you want to make sure you have suction with a yank hour. You want to have oxygen, so you could use nasal cannula, non-rebreather, BVM. You want to make sure you have your airway equipment. You want to pre-oxygenate them. You want to make sure you monitor them as well, and you want to give certain medications. And you also want to make sure that you're just making sure that you're monitoring their CO2 as well. So these are some of the medications we can use: ketamine, propofol, ketofol, etomidate, Versed, and fentanyl. So I think it depends on the attending often what we're going to end up using in the ED. And then some surgical indications. So one of the big things you want to think about, if they have any sort of vascular injury, which is most common in inferior dislocations, you want to consider an ortho and a vascular consult. If they have any sort of fracture of the surgical neck or humeral shaft, you don't want to reduce in the ED. If they've had the dislocation for more than 7 to 10 days, then there's a risk of, there's a high incidence of vascular injury and fractures in reduction attempts. So you want to make sure that you don't do it if they've had it for a long time. Same thing with older adults. You want to be really careful with them because they're just higher risk of injury and fracture. And then if a deformity involves more than 25% of their articular surface, they may need to go to the OR. So it's something to consider. And these are my references.